What a nice introduction. None of this happens unless you have the only skill I've ever admitted that I have, and that is my ability to identify really talented people to work with. And frankly, if he hadn't been sitting there, it may not have happened. I also want to acknowledge one of the most gifted public health officials I've ever worked with, who many of you know, Dr. Earl Fox, who worked with me for so many years at HHS, an extraordinary figure and the advocate for the Santa Fe group to get me here to talk about oral health. I have to admit, though, it wasn't just my idea to do the report on oral health. I was being examined by my own dentist. He wasn't looking at my teeth. This is a very important thing. He was looking at my jaw. He was examining my jaw. And he actually said to me, "How come we've never had a Surgeon General's report on oral health?" I had no idea. But I went back, and we didn't have a Surgeon General at the time, which gave the secretary enormous power, by the way, since I didn't have to consult with anyone other than the senior public health officials, including Earl. And then I was smart enough to pick up the phone and call Harold, and he was at the other end of the phone. And that's one bookend for what I'm going to talk about. The other bookend occurred 6 months ago when I had minor oral surgery, and the oral surgeon handed me, after I had the surgery, a bottle of opiates. And I said to him, "I don't think you're supposed to do this anymore." And he said, "But you're going to have some pain." I said, "I think I'll take an Advil." And I literally handed the bottle back to him. I was only 3 days, I think, but I put those two bookends in place because public policy isn't made in a kind of systematic way. It's not a group of experts sitting around thinking up, what should we do next and how to anticipate the future. Sometimes it's a conversation between two people. In my case, a conversation between me and my oral health provider, who is since retired, but has taken great credit over the years for inspiring me. And sometimes it's the result of evidence, and an idea grows out of that evidence for how you can improve the public health. But what I learned over the years is that you cannot have comprehensive care without integrating oral health. It's as simple as that. And surrounding that is not only evidence that we have and that we need for the future, but more importantly, a very complex politics. It's not as easy as CMS making a decision, as you well know, because there are so many stakeholders, and this is true of healthcare itself. There are so many stakeholders that like this fragmented system the way it is, because they make a lot of money out of the organization. At a hearing that we had last week on Medicare for All in the Rules Committee, I sit on the Rules Committee, which is the Speaker's Committee. It's the most powerful committee in the House of Representatives, the first committee. It controls everything that gets to the floor, and the Speaker decided that the hearing on Medicare for All should be in that committee. At that hearing, the discussion began, I think, with a statement really from me, in which I said, if we had to design the current healthcare system in the United States, we would not have ended up with what we have now. If we could do it again, we would do an integrated health system, and we would have integrated oral health into that, not as an add-on, but as healthcare. There'd be no question about that. But we have what we have. And of course, Medicare for All, which is both an ideal and a piece of legislation at the moment does integrate oral health into its proposal because it starts from the beginning. It takes what we have and tries to fundamentally reorganize it. The Surgeon General's report taught all of us a lot. I've read it twice, 2 or 3 times, in part because I've given commencement addresses at dental schools. And so I went back and read the report. And fundamentally, it says that oral health is health care. That's what it says. And how far have we come since then? We've made minor changes to existing healthcare systems at the public, certainly at the public level. We integrated children's oral health, at least preventative health, into the ACA, the Affordable Care Act. But it's treated not quite like an essential benefit like all the other benefits. It's a little bit to the side. And dental societies across this country have been able to get oral health into the Children's Health Plan because they were able to lobby their states, and in many cases also into Medicaid, so that we've had some essential benefits, but we've never fully integrated it into the healthcare system. And that's in large part because of a lack of political will, in large part because there's been great reluctance to add additional benefits without a lot of consensus. We were able to add drug benefits, for example. But look at the results of what we're not, of our failure. 65% of Medicare benefits, of Medicare beneficiaries don't have oral health coverage. I'm sure that's not surprising for all of you to hear, but the truth is those numbers are higher among African Americans and among Hispanics. Half of all the Medicare beneficiaries did not have a dental visit in the past year. Those are horrifying statistics for something that we know is an essential health benefit. And the only infection that Medicare doesn't cover is dental infection. So we have a long way to go. And the out-of-pocket costs, a fifth of the Medicare beneficiaries have spent at least $1,000 in their out-of-pocket costs for oral health. That's the result of not having the kind of coverage that we think we should have. And the evidence is very clear that if you have comprehensive dental coverage, your health generally is better. And so the goal still is to integrate oral health into overall health care. But we've had some successes that are related. We drove down tobacco usage, and we know that tobacco has had a big impact on oral health. We drove it absolutely down by convincing kids that they shouldn't start smoking, because we had a small piece of evidence in the 1990s that told us that if children did not start smoking before they were 18, they would never smoke. And then we made it totally inconvenient for everybody else to smoke. I really call it inconvenience. I still walk past people who are smoking that are way outside of the buildings where they work. And I always say to them, and this is 20 years later, that's bad for your health. And someone who was embarrassed that was walking with me a couple of months ago said, "Why do you do that?" I said, "Because every year I get a letter from someone that said that the fact that I said that to them was the impetus for them to stop smoking." And frankly, if I can help to extend one life in this country just by being a little obnoxious, I'll do it. Certainly our perceptions have changed because of the Surgeon General's report and because of a lot of work so many of you have done in this country. But tobacco was very important. But of course, the tobacco companies have now pivoted with some new companies, and we now have kids on e-cigarettes and flavored cigarettes. So Congressman Frank Pallone, the chairman of Energy and Commerce, which is the big health care committee, which I'm not on because I'm just a freshman. As I've said to Nancy Pelosi, I'm a freshman, but I'm not a rookie. Please, Nancy, let me play in this area. So we've introduced a bill that would extend the age for purchasing those products to 21. But here's where perceptions have changed. We introduced that bill, and 2 weeks later, Mitch McConnell said he would introduce a companion bill in the Senate. So we're going to take another big step in public health by taking on e-cigarettes and flavored cigarettes, and that's one of the bills that we may be able to get passed this year. And that will be a remarkable, considering the fact that no one talks to anyone of the other party in this town, though they really do. You just have to find the areas where you can take a giant step forward. And that will be one of the giant steps that I hope we can take by the end of the year, because there's consensus. And frankly, Mitch McConnell comes from a tobacco state, but it's not a tobacco state anymore, because in the 1990s, we transformed attitudes about tobacco, about the companies themselves, and working with state governments and with local governments and with school districts and with some remarkable organizations that took on tobacco and children, we actually changed smoking habits in the United States. Now, there are still people in my district that smoke cigars. They're Cuban cigars, so there's an exception. But we did change perception. And people that talk to me all the time saying, well, we have to keep taking incremental steps. We can take giant steps. The Surgeon General's report on oral health had an impact. And we were able to do things on tobacco, which was directly related to oral health. We even got American baseball to change their rules about chewing tobacco. You can't chew tobacco in the major leagues anymore. And so we were willing to take on major issues, but to do that, you have to build consensus in the country. Consensus was built about the drug benefit for seniors. And it was a Republican president that was able to pass Part D. That consensus has to be built for oral health. We have to make the case, and we have to get rid of the divisions and the tensions to make the case to build a consensus so there's a steady drumbeat that brings together the politics to integrate oral health into all of the major insurance plans in this country, both public and private. There are some changes that you can observe. I visit federally qualified health centers all the time. All of them are doing something in oral health now. They're all making a difference, and Earl had considerable impact on that. So, at least in clinics, we're starting to make, in great public hospitals, you'll see facilities that provide, but it's not a consistent, integrated part of the healthcare system, and that's what we need to do in the future. We need more research that's very clear, and part of building the consensus, from my point of view, is associated with oral diseases with other diseases. To the extent that that lifestyle changes have an impact on disease and on oral health, to the extent that we can make the case of the connection between the two where there is evidence, it will help us to build that consensus. And we have to take on the disparities. Part of our argument has to be that there are too many disparities in oral health. That if you're poor, if you're black, if you're Hispanic, if you're a new immigrant, you have less access to first-class care and therefore we need to integrate it. And then we, of course, have to take on lifestyle decisions that people are making, whether it's tobacco use or nutrition or exercise, because that, in part, will help us to finance what new benefits we want to introduce. I think that the 2020 report, the next report, which will talk a lot about the science. I read the registry. You should all go read the registry. They have to put out for a Surgeon General's report a discussion of what they're going to cover. They're going to build on the previous report, and they're going to bring us up to date on what impact the previous report has had. But then they're going to build a bigger science component, it looks like, to make the case. That report can be the lever, the hook, for a significant step and a significant argument, particularly the Congress and the private insurance companies, about integrating health. You always have to have an angle. You always have to have a hook to build consensus around. And the government won't have the money to talk about the report very much around the country, but everybody else can. And we've got to use that report to build consensus for the future. Finally, we've got to eliminate some of the barriers to practice. Every state has licensing proposals, and often there are barriers to practice, and we have to sort out who's going to do what in oral health in a much fairer way that expands access. You know what I'm talking about because the politics of the states are different from state to state, and it doesn't make any difference whether you're a red state or a blue state. It depends on the tradition of the profession in that state as to what kind of barriers. In my state of Florida, you can take the mental exam, you can become an MD, you can take that exam in Spanish, but you can't take the dental exam in Spanish. That's the barrier. And as we attract more people from other places, I believe we have to hold them to the highest standards. But to the extent that we need more professionals in the field, we have to figure out how to give them access. I represent a district that's 70% Hispanic, in which has the highest enrollment in the ACA in the country. There are 100,000 people enrolled in Obamacare in my community. We are great advocates for the ACA. I have no idea what political party they belong to, by the way. Every single clinic, every single hospital has a sign outside, enroll for Obamacare here. And they will do the same thing for oral health. And they're desperate to integrate oral health. My community is desperate to integrate oral health, but we don't have enough providers. And having enough providers is absolutely critical to our future. Let me also say that the misuse and the use of opioids is raising new issues of pain management, which is related to the profession as well. And it also is an opportunity for the profession to lead in this area, in the area of pain management. And the use of opioids has become an issue for every part of the healthcare system, but it also is a dramatic opportunity for all of us to make a difference. Finally, let me say one more thing before I take some questions about the debate that's going on in Congress. Because the Democrats control only one house, we will shore up the Affordable Care Act. Today I'll manage on the floor an attempt to stop the Trump administration from these junk health care plans. Our bill, which stops them, is related to their attempt to eliminate a number of elements of Obamacare, including covering every medically necessary procedure, and eliminating people who have cancer or diabetes, or they're simply not going to cover pre-existing conditions in these junk plans that are coming out. But everybody's using the language in different ways. And today on the floor, the debate will be, if you have language saying you're going to cover pre-existing conditions, is that enough? It's not enough if what you do is put lifetime limits on the plan. It's simply, if you have lifetime limits and you still say that you're going to cover all necessary services, you can't do that, because cancer cannot be paid for by a lifetime limit, because you don't know at what point you're going to be able to control the cancer. But it's true of every other disease. So unless you do things like eliminate lifetime limits, unless you make sure you're not charging more because someone has a pre-existing condition, you don't have coverage of pre-existing conditions. So part of the debate this year will be, what does the term pre-existing conditions mean in the context of health insurance? And that's what we'll debate today, and we'll try to stop and to make it very clear to the American people that these short-term junk plans are not really health insurance. They're in fact consumer fraud as such. Second, we'll do something about surprise billing, which is a particular problem for people in the medical area. You show up for an operation, you say, does my insurance cover it? They say yes, and then you find out afterwards that the anesthesiologist wasn't in network. Many states, a number of states have passed bills for this. We'll look at the best ones, and we'll have a national standard, a national piece of legislation for surprise billing. That is a bipartisan approach. The third step we'll take is we'll increase the age for purchasing tobacco to 21. Those three things may be, and protecting the Affordable Care Act, may be the only things that we're able to do. Do I believe that we should add oral health to Medicare? You bet. But I don't see the politics of it because there is just not a stomach on the other side for expanding public health insurance of any kind. Even though it's going to be delivered by the private sector, I just don't see the politics, because there's an aversion to expanding the role of government, period. And we're just going to have to, next year, hopefully with the Surgeon General's report, make the case. But I actually think we're close in oral health. If we can take that report and spin off of it and make the case to the American people. We always take giant steps when there's consensus about the problem and when there's consensus about the solution. That's when we take giant steps in social policy. We did it on Social Security, we did it on Medicare, we did it on Medicaid, we did it on Part D, and we did it on Obamacare, even though the politics was difficult. So those are the elements that we have to have. And you could be assured that I will be an enthusiastic leader of all of this because I've been well educated by a Surgeon General's report and by so many of you. Thank you very much.